Well, good afternoon and welcome, folks, to today's Dissemination Research and Implementation Science Seminar. My name is Heidi Brown, and I am an associate professor in the Department of OBGYN and one of our core faculty on the D&I Launchpad at UW-Madison. So this seminar is something we started in August, and it's meant to be an interactive monthly lunchtime seminar to learn more about the growing science of D&I and what's happening across campus and in our community. I'm so grateful to you all for being here today. And hope you'll continue to join us for future sessions. We will be putting in the chat the link to sign up and add it to your calendar. I am so excited to introduce Dr. Jay Ford, who is presenting today about applying a health systems engineering approach to dissemination, implementation, and sustainability research. Jay is an associate professor in the UW-Madison School of Pharmacy. His background as a health systems engineer and quality improvement expertise contributed to his interest in D&I science. In his research, Dr. Ford actively works with healthcare organizations, coaching staff through the process of implementing and sustaining organizational change, which all of us know is no small feat. This hands-on experience highlights the importance of designing D&I research projects and promotes strong stakeholder and participant engagement. Dr. Ford's current research supports community pharmacies as well as behavioral health organizations in using implementation strategies to improve the quality of care and improve patient outcomes. I'm really excited to hear what Jay has to say today. He'll talk for probably 30 to 45 minutes, somewhere in there, and then we'll open it up to questions. Please feel free to put questions in the chat throughout, and I will elevate them during the question and answer. And with that, I will let Jay take it away. Thank you so much, Jay.
Great. Thank you very much, Heidi. I'm going to share my screen here. Which is always a very interesting feat to get started. So I'm glad to be here and to have the opportunity to talk to you kind of about applying health systems engineering approach to dissemination and implementation, as well as sustainability research. Just to kind of focus, we're going to kind of try to achieve these three objectives, hopefully today, to provide an overview of health systems engineering, at least from my perspective, to talk about how health systems engineering is an integral part of D&I research, and then to discuss some example projects of how the health systems engineering principles have been applied to D&I research. But before I start, I always want to share Lisa's story with you, because I think it kind of sets the stage for the work that I've been doing over the last 20 plus years and even longer than that. So Lisa's finally ready to address her ongoing addiction to heroin and her underlying mental health conditions, depression and schizophrenia. So she started calling local addiction treatment clinics. The responses were disheartening. Despite being ready to get treatment, Lisa had to wait 28 days for an initial financial appointment before she could even schedule a screening intake appointment. After attending her financial appointment, Lisa no-showed for her first intake appointment because she missed the bus. After missing the second appointment due to a relapse, Lisa made it to her third intake appointment, where she was only screened for her opioid use and not her underlying mental health issues. This concerned Lisa because she knew that her depression and schizophrenia were impacting her relapses and her recovery efforts. After the assessment, Lisa was only offered group counseling for her heroin use, but the staff could not address her mental health issues. She also obtained a prescription for naltrexone injection, which the staff indicated she should be able to get at a local pharmacy because, quote, they do injections, unquote. Although not ideal, she agreed to their treatment plan and walked out with her prescription. Lisa continued to miss her treatment sessions and never found a pharmacy to fill her prescription. After missing several sessions, the clinic called Lisa to issue an ultimatum. Come to the next group session, or we will discharge you from the program. She never returned because Lisa had succumbed to her addiction and died alone in a back alley. Now, this is a fictional story to emphasize the point that we are all about, in my research, is all about trying to improve processes of care for individuals like Lisa. So in our research group, we're really seeking to try to conduct organizational dissemination, implementation, and sustainability research to identify some of the most effective implementation strategies to expand the use and adoption of evidence-based practices to improve patient outcomes and quality of care. And we take a focus and an approach to doing that by trying to advance the use of dissemination and implementation strategies to develop sustainable interventions and implementation strategies, and to kind of understand the organizational attributes associated with that change. And a lot of this work around implementation and sustainment facilitation is really focused on two areas. The first and the most primary is addressing the opioid epidemic, and in particular, more recently, working with community pharmacies to address that. I'm also working with, Dr. Chris Cernich and others to figure out how to improve antibiotic stewardship in long-term care. But as I talk about this, what I really want to highlight is that the research that I'm doing is really grounded in this idea of health systems engineering. And a systems engineering approach, right, can really help critical care environments and the processes to understand, the patient experience and figure out how to develop and design an effective system of care. What I've learned over the last 20 plus years, is that success comes from listening to your customers and understanding the process from their point of view as you move forward in designing your implementation strategies or your interventions. So when I look at the perspective of health systems engineering, and I used to be a health systems engineer at a hospital system in Tennessee, but what it starts with is this idea that systems engineering, can help re-engineer these critical environments to improve both the patient experience and the effectiveness of care. And it starts simply with, kind of efforts to examine, the system and process design, and do that by seeking customer and staff input. So once that's been identified, then you can move into the arena of trying to identify innovative solutions to address these organizational goals, to improve work processes, and to impact the quality of care. Now, a lot of the work that I've done more recently, and even some of the historical work that I did, was really implementing changes that are modified as needed, taking a quality improvement approach to where you're teaching organizations how to use and implement system changes. And the work that I'm doing now, these efforts are supported by implementation strategies such as external coaches, or learning sessions, or evidence-based toolkits, or access to a website. And all of these are driven with the idea that we want to be able to examine the impact on outcomes and processes, and then figure out how to sustain these changes over time. So when I think about this from the perspective of a health systems engineering process, I go back and look at some of the tools that I learned in my training about how we can apply health systems engineering process and tools, to move things forward. So the health systems engineering processes that we're going to talk about some today are, examining, system and processes design, seeking customer input, identifying innovative solutions, implementing changes, examining the impact on outcomes and processes, and then sustaining these changes over time. And I'm going to talk about these as we kind of go forward, but I want to kind of start with a little bit more of a story. And that is, when I worked for the Baptist healthcare system, as I reflect back, I was actually doing dissemination and implementation type work even before that's what it was called. So I was using these health systems engineering skills to examine the systems and processes, to identify innovative solutions, and to implement changes to improve the quality of care. And what's interesting, I just was able to attend an ICTR seminar about a month ago about design thinking. And it kind of clicked with me then that a lot of what these processes are and that we've been doing as it relates to D&I can be integrated into this idea of design thinking. We want to understand what's important to the stakeholders. We want to generate ideas. We want to prototype them. And then we want to be able to test and retest. And by understanding the customer, we can figure out ways to implement and sustain the changes. So let me give you an example from when I worked at Baptist. One of the things that the director of nursing, Anita Vaughn, approached me with while I was working there, was this idea to decentralize the nursing station, to put nursing substations down the hall of the facility. And just to kind of paint the picture, the Baptist healthcare system where I worked, the buildings were designed in like a Y-shaped. So there was a central corridor where the nursing station was based, and then there were arms stretching out to the left and the right, that made up the wings of that nursing unit. Those units were about 50 beds. And so we wanted to figure out how can we place a sub-nursing station about halfway down the hall to make it easier for the nurses to provide care to their patients. So we spent a lot of time finding whatever we could, to mock things up, working with the plant and systems engineering people to kind of, well, here's a desk, here's what the room might look like, here's where the, supplies might be. And we would just find things that were laying around the hospital to help create that. And then we'd have the customers, not only Anita as the director of nursing, but other nurses come in and say, this is what we're thinking. What do you think? And they would provide us, input, and we would modify. So we were already doing some of these basic principles, a long time ago. And what was really unique is that the changes we implemented were sustained. And the only reason they're not sustained today is they tore the facility down. So I just wanted to provide that little bit of a background about where we are. So the other thing that I think is important as we move into the examining the system and design is this idea of conducting a walkthrough. It's really rooted in the Kaizen approach to quality improvement, where they're looking at the Muda walk, what they call the Muda walk, which occurs within the Gemba. And the Gemba is the place where the value is added. So that could be a specialty addiction treatment clinic. That could be a primary care office. That could be a hospital. That could be a federally qualified health center or even a school educational setting. And this approach really focuses on, need finding, where you really seek to understand your customer needs, challenges or barriers in order to better understand the processes before you change it. And so these organizations that take these steps, there's research that Dr. Dave Gustafson and others did that really show if you do this, if people take the steps, the time to understand their customers, organizations that are successful at implementing change are 14 times more likely to have, organizations that take the time out to understand their customers are 14 times more likely to be successful when they're implementing change. And Dave and his team, when they looked at this back, 15 or 20 years ago, found out that this one step alone was the most powerful predictor of successful organizational change compared to everything else put together. So in this particular case, we did these walkthroughs in specialty addiction treatment clinics. These are some of the barriers that we found. Poor staff engagement, burdensome processes, slow, they were redundant, challenging in addressing the client's complex needs, and even infrastructure issues. But once you understand what these barriers are, then you can design systems and processes to overcome them. One other tool from the health systems engineering tool belt or toolkit is the use of flowcharts. And these flowcharts can really help organizations understand what the existing process looks like, who's involved, what tools are needed to perform the different tasks, and to potentially identify bottlenecks or errors that may be occurring in the process. And once you do that, you have a better understanding of your process, how things are interrelated. And then as you put solutions in to remove a bottleneck or address something, you can test ideas to see if they worked. But the most important thing, I think, with a tool like a flowchart is it gives you the opportunity to engage the staff, in figuring out how to address the barriers and the processes that exist. And this gives them an opportunity to think outside the box, to come up with innovative solutions that you may not think of as a leader or the implementation coach as you're moving forward. So these are just a couple of examples of flowcharts, that I've developed over time. I've got others. One is related to falls prevention in assisted living. The other one is a nursing home telemedicine encounter. But once we have these in place, we can then begin to identify where the bottlenecks occur and where and how we might implement change. The next part of this process in the health systems engineering kind of toolkit, we've talked about seeking customers, input and identifying innovative solutions. These are kind of related to the ideas of ideate from the design thinking, as well as testing, understanding what the customers think. And these tools like conducting focus groups or interviews or using the nominal group technique or brainstorming are ways that you can go about kind of not only soliciting input from the customers, but seeking innovative solutions to the problems that you're facing. These tools, especially something like nominal group or brainstorming, are really simple and easy to implement. But I want to take a minute to focus on the last one, seeking ideas from outside the field. So what that means is if I'm implementing change, working in a rural health clinic, ideas from outside the field could mean I'm going to talk to my colleague who runs a similar rural health clinic 2 counties over. And I'm going to try to learn how they are addressing that particular issue. But it can also mean thinking creatively and thinking, my process is very similar. Maybe it's very similar to how hotels check their guest in. Or maybe it's very similar to how, car salesmen, engage with their customers. And yes, I had an addiction treatment agency that we were working with that actually went to a used car dealership. Probably one of the few times somebody went to a place like that voluntarily to learn something that wasn't involved buying a car. But what they wanted to know is, how do the car salesmen engage their customers? And then they took those ideas and brought them back to their organization to try to figure out, how do they maintain and keep their clients like Lisa engaged in treatment so that they don't fall off and we're not successful at engaging them. So once you've figured out some of these things, now comes the steps here in the design thinking, where you want to kind of prototype and test. And that really is where the PDSA change cycle, in my opinion, is one of the best tools for doing that. You're bringing together change teams within the organization, led by somebody that's well respected, that's an innovative thinker, what we often call a change leader, to figure out how to implement changes moving forward in the organization. And so I want to share with you some examples of where we've applied that, in particular as it relates to specialty addiction treatment clinics. So the first one of these, and some of you on the call may be very familiar with this, is Niatex. Niatex was a partnership between the Robert Wood Johnson Foundation and the Center for Substance Abuse Treatment that really focused on providing addiction treatment clinics. An easy to use process improvement model that was designed to remove barriers to treatment and recovery. And these organizations, with funding from both of those groups, Robert Wood Johnson and CSAT, we supported them through a quality improvement collaborative with learning sessions, inter-circle calls, coaching supports. And what we found simply was that just by doing this, that we were able to not only significantly reduce wait time, how quickly people were able to get in and get an appointment, by 37%, about a half a day a month. And we were able to significantly improve the number of people who made it from their first to their second and their first to their third treatment session. Those increases ranged between 12 and 18% of the population. But what was more important is that this approach resulted in these organizations kind of sustaining those changes over the next 20 months. So a simple PDSA process where an organization identified a solution, tested it. If it worked, maybe they adopted it. If it sort of worked, they adapted it. If it didn't work, they quit doing it. And they were able to implement changes that successfully improved and sustained wait time and retention in treatment. We then kind of used that to try to expand and really try to figure out which one of these interventions, these implementation strategies, was the most successful. And there we used, in a study called Niatex 200, we recruited over 201 treatment providers in 5 states. Outcomes were focused on wait time, retention, and admissions. These were the implementation strategies. And what we found was that, learning sessions, coaching, and the combination of inter-circle learning sessions and coaching, improved waiting time. They had coaching and the combination had an impact on annual admissions. And we were able to find that coaching was actually one of the cost-effective implementation strategy for improving access to wait, reducing wait time, and increasing admissions. So as my research has evolved from the work with Niatex, I've still been using those same principles and the same health systems engineering toolkit to move forward and expand that research. So the first one of these was a project that was really designed to help people like Lisa, to help people who had co-occurring, mental health and substance use issues, gain access to effective integrated treatment. So these were some of the research gaps, essentially, that there's a significant issue in people who have co-occurring disorders like Lisa. 7%, less than 1 in 10, at the time were getting access to integrated treatment. And, they were faced not only with, same day access, but they were faced with issues if they needed medication, that there was not a lot of evidence that they could get their medications in a timely manner. So working with Dr. Mark McGovern, who's now at Stanford, and some of you may know, we came up with this study design. We, recruited, approximately 50 specialty addiction treatment clinics in the state of Washington. We randomized them using a waitlist control. This is kind of an overview of the study design. We collected data at 4 different points in time. And basically, these organizations, were exposed to different multi-level implementation strategies, that are shown here on the screen. And so, they had access to, strategies that kind of focused on stakeholder interrelationships. We provided them with interactive assistance. We trained and educated the stakeholders, and we, used evaluative and iterative strategies. The goals of this project were to try to see if the NIATEC strategies improved our implementation outcomes, which include the co-occurring capacity, if they improved patient outcomes, and to try to figure out the extent and fidelity to the NIATEC's implementation strategies. Without kind of getting into a lot of details of the results, we've been able to publish, papers that show the impact of the work that we're doing. Specifically, we found that there was an overall increase in co-occurring capacity. That some of the agencies were able to sustain those changes in terms of co-occurring capacity. That we saw an increase in access to addiction medications, as well as addiction and psychotropic medications, as well as a reduction in wait time to getting access to these medications. But this goes back now to another piece of that health systems engineering process, that toolkit, which is to really examine the impact on outcomes, and the process. One of the key things that I want to highlight here is the focus on interim process measures. And so what I found is that the application of these PDSA chain cycles integrated with kind of this real-time assessment of the outcomes, what we call the little aim, which is often a measure that relates to the big aim, allows for this step in the health systems engineering process to occur in near real time. And this is an essential part of any successful D&I implementation project. So let me give you an example of what I'm talking about. So one of the outcomes that we've looked at in the past is like no-shows to treatment appointments. So in a PDSA chain cycle, first of all, your big aim is to try to reduce no-shows. So maybe you determine that your baseline no-show rate was 40%. And you set an aim that you want to reduce your no-show rate from 40 to 10%. So in that ideate stage, the staff in your organization may have decided, and this is what they did in the specialty addiction treatment clinics, to do reminder calls. And remember, we talked about getting ideas from outside the field. Well, we all know that our dentist or our doctor's office uses reminder calls. But ironically, at the time, specialty addiction treatment clinics weren't using reminder phone calls. They thought it was a barrier. I can't call and leave a message for somebody like Lisa to come to her appointment. Somebody else might learn about her addiction. but that may be true, but also, Lisa may not have remembered that she had an appointment. And that reminder could have triggered that for her. So what these organizations did was they started implementing their reminder calls. And what they found out, first of all, in a lot of instances is, hey, I don't have a working phone number for somebody like Lisa. So they had to step back and implement a PDSA chain cycle to try to get, a working phone number for Lisa. And then the process would allow them to kind of call people for a week. How many of those people we called that now have a working phone number did we get in touch with? Oh, we called 50 people. We got in touch with 30. How many of them showed up for the appointment? Maybe all 30 did. Oh, that's great. But we're still at about a 40% no-show rate because 20 out of the 50 people didn't come. So how do we implement other changes to try to move closer to reducing it? And so each of these PDSA chain cycles kind of had a little aim associated with it, with the idea that by measuring that aim, we were taking steps towards our big aim, which was to reduce overall no-show rates. So then just another example, before I kind of shift to some stuff that we're doing in pharmacy, is this project that we have called SITT-MAT, Stage-Wise Implementation to Target for Medications and Addiction Treatment. And it really is trying to address the issue of expanding access to medications. And even though access has improved, a gap exists, especially for specialty addiction treatment clinics. We were seeing that, a very small percentage of people at the time that this study was submitted and funded, are actually getting access to their medications, and there were contextual barriers like an abstinence philosophy against the use of medications, or a lack of connectivity with a provider who could prescribe the medications, or their, program structural workflows. Now, what's interesting in this particular study is we implemented it, and as is often true in D&I research, it's being implemented in real time. And so for us, one of the real-time things that's going on is the federal government, eliminated the buprenorphine X waiver, which could and should potentially lead to, greater access to buprenorphine, for patients, because the barrier of the number of patients that a physician can follow has been removed. And so that's where, these PDSA chain cycles that we talked about are now being influenced by real-time changes, in the environment in which you're doing that. And you've got to think creatively to address those. So this particular project, as when we started it off, it had these aims, to kind of evaluate the relative impact of the sequence of 4 implementation strategies, to look at the contextual modifiers, and then to also look at the cost associated with the work that we're doing. So we kind of had a conceptual model that's based on strategies that are focused essentially on enhanced monitoring and feedback, NIATEX, medication academy, internal facilitation and external facilitation. And organizations, I'll show you in a minute, are kind of exposed to these, but our strategies are not only addressing system level, but they're also addressing organizational and individual level, attributes that are all focused on, primary outcomes associated with reach, adoption, effectiveness, implementation, quality, maintenance. And so those of you that are familiar with, D&I research, you'll recognize this as the RE-AIM framework. So we've integrated these strategies, with the RE-AIM framework. And so these are our outcomes, up at the top, we're kind of assessing, outcomes related to reach, adoption, effectiveness, and implementation. We've got some contextual outcomes that we're looking at the organizational level, and then also some participation and fidelity and cost outcomes as well. But what's unique about this particular strategy is we're deploying an adaptive implementation strategy where the adaptation is based on actual performance. So depending on how the organization does when it is exposed to a strategy like enhanced monitoring and feedback, if they achieve our goals, our target criteria, then they'll move up into kind of a sustainment phase. And unless they relapse at this point or this point, they'll remain on this path throughout the rest of the study. You know, those that aren't successful will get exposed to the next implementation strategy. And again, if they're successful and can sustain that and don't relapse at this point in time, they'll stay on path 2. Those that are still need some additional help will be randomized to either internal or external facilitation. And if they're not successful with internal facilitation, then they'll get external facilitation. So there are multiple paths and multiple opportunities that these organizations can follow. But at the heart of the approach are some of the basic, tools and techniques that we're looking at from the perspective of a health systems engineer. So just to kind of look at the adoption, criteria, these are our criteria that determine whether or not they go to the next sequence of implementation strategies or the sustainment phase. 75% of patients with an OUD are getting a medication. There's an on-site or kind of an affiliated prescriber. And then they have an IMAT, which is a score of integrated medication capacity of 4 or greater. And again, as I mentioned earlier, those system changes can really drive some of these measures, especially with the removal of the buprenorphine X waiver. These are some of the strategies that we're, applying here. I'm not going to, dwell on how they are structured, but just wanted to kind of give you an overview of that. And then we kind of move to one of the last pieces of this health systems engineering toolkit, which is to sustain the changes over time. Now, I've done some research, and I know others probably have, maybe on this call. I know there's a lot of emphasis in the D&I community on sustainability. But I would argue that integrating health systems engineering processes to address sustainability or sustainment of change is challenging. The evidence would suggest that similar approaches associated with implementation and the use of health systems engineering would work. However, what I've found is that sustainability really is a tough nut to crack in this field. And I think it's still really a generally untested area of D&I research where we know a lot about the organizational attributes that support sustainability, but we don't know what implementation strategies or innovations are really needed to help support the sustainment of the changes over time. And I would argue that from a health systems engineering perspective, that things like developing a sustain plan or appointing a sustained leader are successful. And that seems to be the case when you look at some of the work that I know has happened at Johns Hopkins University related to sustainability. So now, I want to talk a little bit about pharmacy D&I work. And what I wanted to emphasize here really is sometimes an area of new research requires that you return to the start of the health systems engineering process. And that's what occurred here. So what we're talking about is implementation and sustainability. And we're trying to recognize that until recently, this approach hasn't really been applied, at the community pharmacy level or part of the community pharmacy or pharmacy research agenda, and especially the pharmacy D&I research agenda. So when I say it requires you to go back to the beginning, what do I mean by that? It means simply that we had to go back and to try to seek out information from our customers through focus groups and walkthroughs, at the community pharmacy level in order to understand, what it is that's needed as it relates to naloxone distribution from a patient perspective, and what does the long-acting injectables intervention look like in a community pharmacy. So the first one of these, one of the first things we did was to try to figure out what is important to the customer. What does the customer need to know as it relates to naloxone consultation? And then we talked to pharmacists and prescribers to understand what do they need to know about long-acting injectables and why is it beneficial to go to the community pharmacy. So the first conversation with customers led to the development of a series of naloxone-specific brochures. We actually ended up developing one brochure for each of the 3 types of naloxone medications that were on the market at the time. The brochures are the same, except for talking about the medication and how it's administered. But we designed this with input from the customers. So hopefully by seeking customer input, it's going to result in an innovation that is beneficial and useful, not only to the patients that are coming into the pharmacy, but also beneficial and useful for the community pharmacists. We also used a similar approach to kind of come up with some brochures about why should you go to a community pharmacy to get an naltrexone injection, a Vivitrol shot. We talked to providers and pharmacists, and we came up with a checklist. What are the benefits to the patient? What are the benefits to the provider? Why use a pharmacy? What the patient would expect at the pharmacy. And we put this into kind of a marketing brochure, that community pharmacists can then use to try to expand their business and to kind of get more physicians and providers to refer patients to the pharmacy. But even with that knowledge, we have to understand, what does the process look like? And so, we, again, interviewing pharmacists, we figured out what is the typical, naltrexone injection process look like in the community pharmacy. We use these tools like from health systems engineering, like flowcharts, and we also then focused on some of the simple outcome measures to figure out. Sorry, the color changed here, but this is really the purple now is kind of the pre-injection, the orange is the injection, and then the blue is what happens afterwards. But we use this workflow to help us figure out the average cost of time and cost associated with providing this service. And so, we identified that on average, it was 123 minutes, and $93 for a new patient versus 83 minutes and $66 for a returning patient. But remember, when I talked about flow charting, if we have this, then we can identify, where bottlenecks and barriers might occur and try to implement changes to address those. So when I come back to it, I think about this health systems engineering approach really looks at, kind of this model at the top, using some of those tools that we've talked about. And as I said at the beginning, the design thinking, that workshop that Ictor put on a couple of weeks ago, really made me realize that a lot of the work that I've been doing really does kind of fit into that flow of understanding the customer, figuring out innovative solutions, prototyping, through PDSA chain cycles to understand what that's going to be, and then test them, see what the stakeholders think, what needs to change, and just kind of repeat that process until you get a sustainable solution. So with that, I'll stop and open it up for questions and answers from, or questions, I guess I'm giving the answers, but questions from the audience. So.
Thank you so much, Jay. That was really interesting. And I was thinking how I need some of your slides to describe one of the research projects I'm doing right now. um, so I really liked those diagrams and the way you depicted the processes. I wonder if you could talk a little bit about the various folks whose input you seek when you're devising solutions for any of the examples. Because it seems to me like there are lots of moving pieces, and when folks don't know much about user-centered design or design thinking, they might be focused just on thinking about, for example, the patient. But can you talk a little bit about the various perspectives that it's important to incorporate when you're thinking from a health systems engineering perspective?
Yes, that's a great question. So back when I worked for Baptist Hospital, we sought input, not only from, the clinical nurses that were on the floor, but, we talked to, oftentimes talk to architects, we talked to, the plant operations people to try to figure out what was going to work in terms of designing the solutions. That said, when we've done other work, in specialty addiction treatment clinics, a lot of times the focus is not only on the customer, but is talking to the staff that work in the organization, the people who greet the customer at the front door, the clinician that's providing the care for the customer or the patient, the leadership of the organization, who they are and how they're going to kind of drive, that approach. And then when we talk about some of the work, just by a different way of example with, the long-term care, again, it's been, nurses, but we've also talked to, the CNAs, the LPNs, we've talked to providers, we've even talked to, the tech people that are, managing the electronic health record in a nursing facility to understand, how the system works from their end. And so you're kind of bringing all those pieces together to kind of understand the process. I don't think you can assume that you're going to learn everything just by talking to the patient or just by talking to, the clinic manager. Because I will say, one of the things that I've learned is oftentimes leadership in an organization has a very different perspective about what works and what doesn't work compared to the frontline staff who are dealing with it on a day-to-day basis.
And how important is it to sort of share those different perspectives from the various different, folks impacted with one another? And how do you go about doing that?
So I think it's critically important, to share those perspectives. And there are a couple ways to look at it. I mean, obviously, you as the health systems engineer or as a D&I researcher can kind of gather that input, independently, and, just represent the points of view, for the different groups. I know some of my colleagues here in the School of Pharmacy, will take an approach where they're maybe conducting interviews and focus groups with patients, and then maybe they're conducting interviews and focus groups with pharmacists to identify solutions. But then at the end of the day, they bring those two groups together to share ideas, to try to develop and create a common, goal and objective about what's important. That's one of the beauties about the nominal group process. Is that I could bring together, everybody on this call, to conduct that. And the nominal group process can really help if you do it right, remove the power dynamic of having the CEO of UW Hospital in the room, where you feel like he or she is, controlling the conversation because they become an equal partner in that process. So that's where that tool can come in really handy.
I see that Barb has her hand raised, but I would also ask if you have recommendations for where one can learn more about that technique.
Yeah, then I can, I'll I'll find something out. Can I just send it to police when we're done at the end? So,
That's perfect. I think it would be a nice adjunct. Okay,
okay.
Barb.
Great presentation, Jay. I always learn so much from you every time I hear you talk.
Thank you.
I think the engagement of the frontline worker is critical in any type of innovation introduction. What I've learned, particularly from Elise Arsenault-Knudsen's work, is having people that can give a historic perspective at the front line. So when she did work on looking at how nurses adapt evidence-based practice, many times they would talk about, well, we've tried that. And, 5 years ago when we tried that, here's what happened. And so now things get recycled back because you have new leadership, new ideas, and there's a level of frustration that actually occurs. So trying to adopt an implementation, there's an immediate barrier because this didn't work last time. We had the same problems. The reason why it didn't work. So having a representation of those voices in who you're talking to seems to be, I feel is pretty important, and being very thoughtful of who do we need to chat with?
Yeah.
And what type of history is present within an organization. And I absolutely agree. I separate the administration from the front line every single time.
Yeah. That's a really good point, Barb, because I'll share another story. When we were working with specialty addiction treatment clinics and looking at their paperwork, we'd go in and they'd have a stack of paperwork, and you'd ask them, well, why are you, why do you have these 5 forms, with this 100-question survey, and, you're asking people to sign, 3 consent forms, before they ever get into treatment. And sometimes the response would be, I remember the day, that Dr. King came in and had us implementing this study, and this was all her stuff. And this is what she wanted us to do. And then you say, well, how long ago was this study with Dr. King? Oh, it was at least 10 years ago. And then you'd have to ask them, well, why are you still doing this? We don't know. And we would get sometimes that kind of a response. And you'd be like, okay, well, you're no longer doing this study with Dr. King, so why do you just not collect this paperwork anymore? And, then they might find that they reduce the time and the amount, from 45 minutes to an hour to complete paperwork, to 20 minutes. So it is really important to get these different perspectives, along the way. I agree.
Thank you so much for that, Dr. Ford. I'm thinking about the intake paperwork that I completed yesterday when I took my son to the doctor, and I filled out our name and our insurance 3 times. It looks like Dr. Mahoney has a comment, and I just want to remind folks to please complete our survey, evaluate this seminar. This is a new seminar. We launched it in August, so we need your feedback about what's working and how we can improve it. Dr. Mahoney, why don't you take us home?
This is fantastic, Jay. Just a couple of questions. If you could think about and sort of tell us your philosophy and principles for how at both the level of delivery to patients and maybe at the level of adoption, you think about the equity aspects. So, for example, you're dealing with all hard to reach people, but within that, there may be differences related to culture, to background, to other socio-demographic and social determinants of health. How you think about that at the actual aspect of improving the direct hands-on delivery of care to patients. And then at the level of adoption, some addiction clinics may be affiliated with more affluent health systems and dealing with sort of more affluent systems to support their work. And so how do you also look at this equity at the level of adoption?
So those are great questions, Jane. Equity at the patient level, sometimes I think what's important is to recognize that I may not be the right person to get that information, from the client. And I may need to bring somebody else, to be a part of my team, who does a really, a much better job at addressing that. We did have, when we were designing these naloxone brochures, we worked with winners and the cards group here on campus. And, they brought a very unique, different population to the table. And it was really, really important, for our team to listen to what they were saying and to adapt, because they're the ones on the front line who are saying, yeah, I need to know what's going on. We need to understand the issues around a potential overdose so that we can know how to give somebody naloxone if needed. From the systems level, I'll be honest, over the years, I found that some systems just don't want to change, and they may be the affluent ones or they may not be the affluent ones. And, you really have to reach out and really take the time to try to understand what's important to them. And that may require some extra steps of listening. That may require, didn't talk about the use of snowballing, as a way to kind of identify key players, but it may be that I start talking to this person and they're saying, well, you really should talk to another person in the organization, or you should have talked to another person in the organization. So sometimes it's really important to follow that trail, to make sure you're soliciting input from multiple people. And that could be something that's true in an affluent, organization, as well as one, that is just trying to, get by offering, free services in the community.
Well, I want to wrap up with 3 minutes to spare here so that folks can have a bio break before their next commitment. Let's give a warm thank you to Dr. Ford. Please fill out the evaluation. Thank you so much, Dr. Ford, for sharing your stories and your talk. It was really wonderful. And I've already sent you an email asking for your slides.
Okay. All right. Great. Thank you very much. I appreciate it. Thanks for the opportunity.
Have a wonderful weekend, everyone.
Okay. Bye.
Bye.